Well, good morning, everyone. Well, good afternoon for some. I'm Angel Soto. I'm the Associate Director of Education for the Mission Delivery Team of the National Scleroderma Foundation, and I'm very happy to welcome all of you to today's webinar. It's a very exciting topic on Beyond the Crisis, Scleroderma in the Kidneys, and it's being led by a fantastic speaker, Dr. Gaddy. But before we get started with the webinar, I do want to go over a few kind of housekeeping things just to make sure everyone's connected properly. If you are connected to the webinar properly, you should be hearing my voice and seeing the doctor and myself on screen. If you are having any audio or visual difficulties, you can chat me at the bottom of your screen. There's a chat function, or you can try logging out and logging back into the Zoom platform. Today's webinar is being recorded and will be made available at the end of the week. So if you want to rewatch the webinar, feel free to jump onto our YouTube page at Scleroderma US. The National Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. I also want to mention that if you do have any questions throughout the webinar, feel free to throw those in the chat, and at the end of the event, we'll be going through any questions that have popped up in chat or in the Q&A feature. All right, let's get started. I'd like to introduce our speaker for today, Dr. Gaddy. She'll be speaking on Beyond the Crisis, Scleroderma in the Kidneys. Dr. Gaddy was trained in Indiana University Medical School. An internal medicine residency at nephrology fellowship. And a nephrology fellowship. She's also an assistant professor in the Division of Nephrology. Thank you very much for joining us today. The floor is yours.
Oh, thank you so much. Thank you, Angel, and thank you for having me. I really appreciate this opportunity to talk with you all. And really, I hope to hear, I've left what I hope will be quite a bit of time. I tend to be a little verbose, but I hope to have some time afterward to hear people's questions, but also people's comments and experiences. So I was hoping to give a talk about all the different kidney manifestations of. I titled this talk after trying to think about all the different kidney manifestations that might come about for a patient who has scleroderma, and of course, as you know, and as was already stated, this is a disease that has number one, is extremely rare, and number two, has a very heterogeneous presentation. So everyone's experience is different, and we always say that, but it's really, really true in scleroderma. And I think partially because of that, and partially because it's not a very common disease, there's just not a lot of data out there. And so what you're going to see is me presenting to you some of the data and some of my interpretations of the data that does exist, but also bringing up gaps and bringing up some things that are just from intuition. And so, hold on, sorry, I'm having. So I do get consulting fees from several pharmaceutical companies, Calliditas, Otsuka, and Travere. None of those companies make any medications that are used in the treatment of scleroderma. And I do not talk about scleroderma with those companies. And I won't be discussing any products from those companies. So today I'm hoping that we can review the epidemiology of kidney or renal disease in scleroderma. I would like to talk about the mechanisms of primary kidney damage that can occur in scleroderma, and then also secondary, meaning not from the disease itself, but from the treatment of the disease, or from side effects of the disease. And then I would really like to, by using those mechanisms, help you develop a framework in your mind of the possible ways that kidneys might be involved in this disease, so you can live a life that is the most healthy for your entire body, including your kidneys, and how to inform that given that you have scleroderma. And I will going to try to be very careful about this, but the words renal, kidney, and nephrology or nephrologic are synonymous. There's no difference in what those mean. There's just historical we just use them interchangeably, and so I apologize. They all mean the same thing. So the first thing I wanted to bring up is that patients with scleroderma oftentimes have trouble keeping on weight and maintaining muscle mass for a variety of reasons. And so one of the big limitations in terms of defining kidney disease is that even knowing if someone has kidney disease is typically detected by checking a basic metabolic panel, which is like routine blood chemistry, and then looking at someone's serum creatinine. We use that serum creatinine to get a sense of how clean your kidneys are getting your blood, because creatinine in your muscle actually is a normal breakdown product, and it turns over, releases creatinine into your bloodstream, and your kidneys should clean that out at a constant rate. If someone has a lower muscle mass than normal for their age or their gender or their weight, then the creatinine can be a not very good predictor of their actual kidney function. And so I took this picture. You can see that it's cropped. I took this out of a talk that I give for patients with cirrhosis, who often also have trouble keeping on weight. But any state where you have difficulty maintaining nutrition for appetite reasons, for gastrointestinal transit reasons, if you're having a lot of constipation or slow gastric transit, then any malnutrition state, any low protein intake state, or just any situation where you're not moving or as active as you once were, and so your muscle mass is lower, that is going to be difficult for people to tell whether you have kidney disease or not. And I say that because I'll get to this in a little bit, but some of the studies that look at kidney disease in scleroderma use a cutoff for creatinine that I think is probably too high and is probably missing some people who actually do have kidney involvement. So, as I mentioned, one of the things that really struck me as I was preparing for this talk is that there just is not a lot of data. There's not a lot of studies done in scleroderma, and that's not probably a surprise to all of you who live in this space and are active in this space. But to me, compared to things like diabetic kidney disease or lupus nephritis or other kidney diseases, the age of the literature that does exist and the amount of new work being done in the space was pretty surprising. So this is a paper from 2005. This was Dr. Steen from Pittsburgh, and now Georgetown does a lot of work in scleroderma and its different manifestations, and did this study. So this was part of the Pittsburgh Scleroderma Outcome Study, which is a cohort study of basically every patient who had scleroderma and was seen at the University of Pittsburgh between the years of 1972 and 1993 was included in this study. This was actually published in 2005, despite what it looks like. But basically what they did was they said any patient who was seen and had a serum creatinine of over 1.2 or who had protein in the urine, we're going to include in this study. And so this was 600 patients in total, 675 patients in total. So over 20 years, only 600 patients is astronomically low compared to some of the other diseases that I see. Again, a serum creatinine of over 1.2 probably is missing some. It's an overly generous cutoff, I would say, because normal creatinine is probably something like 0.9, 0.8, even 0.7 if you're a very small or lightweight person. So probably missing some people. And then proteinuria is a sign of damage or a sign that your kidney is under stress. So I like that they included that as well. So what you can see here, if you look at this pie chart, is that roughly half of the patients in this cohort, so only 675, but roughly half of those didn't have any abnormalities in their kidney function over the entire period. So that's wonderful. But 50% of patients did. And so looking at the breakdown of what was the cause of that, renal crisis was, of course, as you would imagine, about 20%. And then D-penicillamine, which is a drug that was used to reduce collagen deposition, still is sometimes, can cause proteinuria as a side effect. And so that was about 10% of people. And then new hypertension was attributed to 4% of patients. The other pieces of the pie are just sort of unexplained transient increases in, changes in GFR or filtration rate, meaning blood wasn't filtered as well for a period of time, but then that resolved. And then the 10% is other explanations. So this is not, of course, not a perfect study, but it's nice to have this information to kind of get a sense of what types of things to be aware of as we're thinking about how to prevent or treat or look out for kidney disease in patients. So I know I said I wasn't going to talk about scleroderma renal crisis, or I said beyond the crisis, but in learning more and reading more about the work that's been done, it does seem like renal crisis is at least a good jumping off point, because I think it brings up a lot of the physiologic principles that wind up affecting other causes of kidney disease and scleroderma. So again, we're talking about this 20% chunk of the pie. Scleroderma renal crisis, as you all know, used to be extremely high fatality before we had the advent of angiotensin converting enzyme inhibitors. And I'll get to that in a second. So renal crisis, as I'm sure most of you know, is when there is an unknown provocation that causes vasospasm in the kidney and leads to hypertension. So on the left here is a normal kidney, and you can think about, everybody knows, the kidney is kind of bean shaped, and the blood vessel supply radiates out from the middle of the kidney where the big blood vessel actually goes in, and it sort of radiates out into the kidney. And what you should see is on the left here, this tiny, it looks like trees, and then you can imagine just sort of a really dense canopy of leaves, if those are little tiny twigs and branches of a tree. And that's making sure that every single little segment of that kidney is perfused, getting blood flow, both to keep it alive and so that that blood can be then cleaned by the kidney. On the right here, you can see that not only are the big vessels a little bit chunkier, but there is a huge loss of those tiny little fine filaments. So it's hard to even put a number to how dramatic this is, but you can see that there is a huge loss of that fine, what I would call capillary or very, very small blood vessel perfusion to the sort of meat of the kidney. And so you can imagine that at least 50% of the kidney is not working in this situation because it's not getting any blood flow. And so you can really appreciate that this used to be extremely, extremely dangerous, and still is. So, this is the dreaded crisis, but again, we don't really know what the provoking factor is, what causes this to happen. It does happen fairly suddenly for some patients, and one of the big fields of study in scleroderma is trying to figure out what patients are at highest risk of this happening, because it doesn't happen to everyone. You saw only about 50% of people have this happen. And so one of the things that came up is that there is a certain antibody, an anti-RNA polymerase III antibody, that occurs in about half of people with scleroderma, and has a strong independent risk of developing sclerodermal renal crisis. So this was this picture is not from this paper, but there was a scleroderma cohort in Australia that measured different biomarkers to see whether any of the markers or even risk factors could be predictive of a patient's likelihood of developing scleroderma, and found that patients who had this anti-RNA polymerase III antibody had a 25% risk of developing scleroderma renal crisis in a defined period, compared to just 2%. So basically what this means is there's probably a big cohort of patients who don't have whatever specific risk there is for this scleroderma renal crisis. And if they have a negative anti-RNA polymerase III antibody, then you probably need to worry about other things with that patient and not focus your energy on preventing renal crisis, which is sometimes knowing who is not at risk is just as important as knowing who's at risk. And so I thought this was really interesting finding, and I'd be curious to know if any of your rheumatologists check this routinely. I'm not a rheumatologist, so I don't. Typically, I tend to see people after they've already had a renal crisis, so I know their risk of having a renal crisis is 100%. So, having biomarkers that can tell us who's at risk is a really important thing. But again, you can see that this paper was in 2010. So this is almost 15 years ago now. So I would be curious how much this has been adopted, or if any of you have experience with getting this checked. And so I wanted to talk a little bit about the kidney and how it normally works, because I think this provides a framework, number one, because I'm a nerd, but number two, because it provides a framework for understanding what is actually happening in scleroderma renal crisis. So what happens within the kidney is one of the kidney's main jobs is to actually regulate how much blood you have in your body. And specifically inside your blood vessels. Your kidney actually has sensors within the filtering apparatus that say either I'm getting enough pressure or I'm not getting enough pressure. If your kidneys are not seeing enough blood pressure, they assume that it's because you don't have enough blood volume. And by blood volume, I mean how much blood is actually in your blood vessels. And so what they do in that situation is they hold on to more salt and water to try to bring your blood volume back up to normal. And you've all probably seen this on days when it's hot or you're dehydrated, you haven't been drinking or eating much, or even first thing in the morning when you wake up and your urine is very dark and concentrated. That's your kidney saying, hey, my blood pressure is starting to get a little low. I'm going to hold on to as much salt and water as I possibly can and not urinate out very much. But what actually happens, I don't know, I don't think you can see a pointer, but what actually happens in that situation is if you look over here on the right to the little picture of the kidney, is that decrease in renal perfusion or kidney perfusion actually causes the kidney to release a hormone called renin. And this happens extremely quickly. The renin is actually already produced and it's stored in little like pockets. And so when the blood pressure gets low, the renin is just released and is immediately into circulation. So I want you to remember renin because it's going to come up again later. So that the renin is something that the kidney actually secretes when it senses your blood pressure getting low. Now, circulating at all times is something called angiotensinogen, and that is a molecule that's produced by the liver. When renin enters the blood circulation, it interacts with that angiotensinogen and cleaves it into angiotensin 1. Angiotensin 1 then is acted upon by an enzyme from your lungs called angiotensin converting enzyme inhibitor, or excuse me, angiotensin converting enzyme, and that's, you can think of that as ACE. ACE cleaves angiotensin 1 into angiotensin 2, and then angiotensin 2 does a bunch of things to try to raise your blood pressure because, again, this is your body's signal that your blood pressure is too low. And so this sets off an alarm system within your body that our blood pressure is too low, we're going to pass out, we're going to die. And so basically your body responds in a variety of ways. It makes your heart beat faster, it makes your heart beat harder. This up at the top is sympathetic activity, which means basically adrenaline. So think, fight or flight response. It's the fight response. So it makes your heart beat faster, makes your heart beat harder. It also has a variety of effects in clamping down your blood vessels. So your actual blood vessel diameter gets smaller. You may not think of this, but your blood vessels are not just tubes. They also actually have muscle around the diameter of all of them. And so at any given time, they can just clamp down and make your blood pressure higher. So that happens. But then what is most important for the kidney is that it makes your adrenal gland, which is a little gland that sits on top of your kidney, it causes that gland to release a hormone called aldosterone. And that hormone causes your kidney to reabsorb more salt and water from the urine. So the end result is that instead of peeing out salt and water, like in the form of normal urine, you'll have much less urine output and you'll be retaining a lot of salt. And so all of this is dependent on the kidney correctly interpreting what your volume status is. And so what happens in scleroderma is that when there's vasoconstriction, that affects the kidney. The kidney thinks that your blood pressure is low because it's not seeing a lot of pressure go past it because your blood vessels are clamped down. And it sets off this huge chain of events thinking that it's doing you a favor, but actually what it's doing is causing you to absorb more salt and water, causing your heartbeat to increase, causing all your peripheral blood vessels to clamp down, and it's basically shooting its own self in the foot. And so it sets off this cascade of events thinking that it's doing a good thing and protecting you from starvation or bleeding. But in actuality, what's happening is that it's setting off basically a storm, and that is the sclerodermal renal crisis. This also happens to a much lower extent. This happens very quickly in sclerodermal renal crisis, but this also happens to a much lower extent in some other forms of hypertension that we see just in garden variety patients without scleroderma. So a problem in the system that is supposed to protect you from low blood pressure can actually cause a whole cascade of bad events. So we use ACE inhibitors, and probably a lot of you have experience with these. This is medications like lisinopril, enalapril, captopril, benazepril, anything that ends in pril. or medications that end in artan, so losartan, telmisartan, olmesartan. Those types of medications act, I think I have it here, and they actually block the conversion of angiotensin 1 to angiotensin 2. And so they don't affect the kidney, they don't actually stop the kidney from sensing the aberrant signal, and they don't block the kidney from releasing renin, but they do actually block those downstream of effects and limit the cascade of bad salt absorption and blood vessels clamping down. And so before ACE inhibitors, so these types of medications were invented, the fatality of a sclerodermal renal crisis was about 75%. Is now much, much lower than that because we have these medications. And so probably most of you are familiar with these medications. They also are really good blood pressure medications for just everyone. So just because you're on this doesn't mean that it's to prevent a sclerodermal renal crisis. And if your friends or family members or someone is on this, that's not the only cause or the only use, but that is why they're particularly good at this disease. We do also have, I don't know if I've highlighted it here, we do also have direct renin inhibitors. The common class is called aliskiren. It's very uncommon in the United States. It has some fluid retention side effects and can cause hypotension. But there are case reports of it being used if someone's in renal crisis and just an ACE inhibitor is not enough. So there are other ways to block this pathway, but generally the one that's best tolerated is the lisinopril or losartan sort of class. So I was looking more into, different types of hypertension or proteinuria kidney disease in scleroderma and what's known. And I found some very interesting literature on vascular disease outside of sclerodermal renal crisis. As I mentioned, the renal crisis is when this happens either suddenly or reaches sort of a fever pitch where you get fluid retention, you get edema, maybe in your face, maybe in your legs, and it's a life-threatening hypertensive or high blood pressure emergency. But certainly it's possible for this to be a spectrum, like almost all disease is a spectrum. And most things don't just suddenly happen in the body. And so I found this very interesting. This was a study that was done in a group of females with scleroderma. There are 22 of them, and so those 22 females were divided amongst group 1 and group 2. The group 1 had known scleroderma renal crisis, not necessarily at the time, but they had it. Excuse me, they had involvement in some variety. And then group 2 had scleroderma, but did not have any renal involvement that was detectable. And then group number 3, or the control group, was healthy controls. So same weight, same comorbidities, that sort of thing. And so what you can see here is that the patients who were divided into the scleroderma renal crisis or renal involvement tended to have much longer duration of disease. So 10 years, I'm looking at this, if you can't see my pointer, I'm looking at the second line down. They had about 10 years plus or minus 5, so anywhere from 5 to 15 years of disease, versus the people who hadn't had their kidneys involved was anywhere from 1.7 years up to 7.7 years. So much shorter duration of having diagnosed scleroderma. You can also see that their blood pressures at baseline in this study were pretty much the same. There's not a whole lot of variation between those. And you can also see that the ages were quite a bit higher in the group of patients that had renal involvement versus the patients who didn't. And so I think that's notable. Perhaps the risk just increases with age, was actually one of the conclusions of these authors. So maybe it's a combined effect of, rather than there being one stimulus that one day just causes vascular dysfunction, perhaps this is an accumulation of vascular dysfunction over time. And I think it's worth noting that one of this group actually assigned the diagnosis of renal involvement based on patients who had an elevated serum renin. And so remember that renin that is released from the kidney is sort of the first sign that the kidney is thinking your blood pressure is low. Even before it actually makes your blood pressure high, as a result, the renin is starting to be released. And so I thought that was interesting because I think it was 6 of the patients in group 1 actually had elevated renin, but didn't have high blood pressure yet. And so what this study did was actually, and I know this is a lot of numbers, so don't get bogged down, but what this study actually did was used a Doppler, which is an ultrasound that specifically measures blood flow. And they use that to measure the renal arteries of patients, all the patients with and without scleroderma, and then with scleroderma, but with and without renal involvement. And what they found was that the actual flow, so PSFV and EDFV are peak systolic flow velocity and end diastolic flow velocity. And basically that's just how fast blood is flowing through those arteries when your heart is contracting and how fast it's flowing through when your heart is relaxing. And though it didn't reach significance, you can see that the flow velocities were higher in the patients with renal involvement, and then lower in the patients with scleroderma without renal involvement, and then even lower in the control group. And that was true in both the main renal artery and the interlobar artery, which is the smaller artery feeding off of the main renal. And so then what actually did reach statistical significance was that the resistive index and the peak index in the patients, so that's the RI and PI, was significantly higher in patients who did have renal involvement versus patients who did not have renal involvement and versus healthy controls. And so what seemed to be the sort of tipping point was when the resistive index actually became higher. And so I think that it's worth noting that this demonstrates that even outside of the context of someone who's overtly in renal crisis, there is a difference between patients who have scleroderma with renal involvement in terms of what their blood vessels are actually doing. And so this study is obviously just descriptive and just kind of says, hey, look, here's a pattern, doesn't describe the mechanisms of why. But it's reasonable to think that if someone has started to have increased blood flow and higher pressures, meaning their resistive index is how high their pressure is inside that vessel, it's reasonable to think that once that starts to happen, then that patient starts to secrete renin because their kidney is already getting abnormal perfusion. And so this paints a picture, I think, for me, that scleroderma renal crisis may not be a thing that happens, one day. It is something that might be happening over a prolonged period of time. This may be something that in your first year of having scleroderma, you're relatively unaffected, but over years and years, you start to develop more and more constricted arteries and more increased pressures within those arteries. And then your kidneys start to say, I should start releasing renin. And so as of right now, most people are not treated with losartan or lisinopril until they actually develop renal crisis. But I think that probably needs to be reevaluated. And so again, I'd be interested to hear, whether people are doing this. There's not a lot of great best practices when it comes to scleroderma, and I think that's just because of a paucity of evidence. But in terms of blood pressure control, if your blood pressure right now, if your blood pressure is not abnormal, meaning if it's not high yet, and you can see that these patients, for the most part, didn't have high blood pressure yet. But these patients in group 2 had abnormal resistive indices, and even in group 1 had abnormal resistive indices, but they had very normal systolic blood pressure. So systolic blood pressure of 121 or 122, I don't know many people who would treat that. That's pretty normal and good. And so I think there is definitely a role here for considering either direct renin inhibitors or some sort of ACE inhibition early on, particularly if a patient has high blood pressure. So checking renin levels might be a very early predictor of incoming kidney problems. So in a dream world, we would have a biomarker or some sort of a risk assessment to say who's at risk for this, who do we need to be treating empirically, meaning before something happens, and then how do we prevent this from happening. And I think it's reasonable to think with more evidence, we could create a framework for how do I identify patients who are at risk. So that anti-RNA synthetase antibody I talked about earlier might be one good biomarker. And then do we start to treat those patients prophylactically or empirically for their elevated renin? But none of that really helps you in the here and now because that's not part of a protocol, and that requires very individualized care. So what I do want to talk about also is secondary damage that can happen to your kidney or just outside of renal crisis or the actual blood vessel thickening that is part of the disease process. And so To do that, I need to talk about a little bit more physiology. I apologize, but I think it makes more sense if you understand what's going on, because otherwise it can be very confusing, I think, to hear things like, oh, low blood pressure is good for your kidneys, but too low is bad for your kidneys. Higher blood pressure is good for your kidneys, but too high is bad for your kidneys. So everything is about moderation, and I think it helps if you understand the system so that you can understand why. So angiotensin 2, which was the last molecule in that pathway that I talked about, and this is what's blocked by angiotensin, the lisinopril losartan type drugs. This actually has a couple effects on your kidney. And so what we're looking at here is a schema of the blood flow into your kidney and the blood flow out of your kidney. And this little white arrow is the direction of blood flow. So you can see that the blood enters the glomerulus, or the actual filter of the kidney, via the afferent arteriole, and then it actually gets pushed through that filter and into the urinary space. So what's supposed to happen is that that filter filters out the water and the salt and the toxins, but doesn't filter out any of the blood or the protein. And that's why in your urine, you don't see protein and blood, you only see basically water and salt. And so then the whatever is left goes out the efferent arteriole, and then that clean blood goes back to the rest of your circulation. And so the amount of pressure across that filter is actually determined by the difference in pressure between the blood coming in and the blood coming out. And so each of those hoses, the in hose and the out hose, are actually under their own control, and they have different muscle control that actually dictates what their diameter is. And so by doing this, your body can actually regulate how much blood is being filtered per minute. And in times of low blood pressure can decrease how much blood is being filtered, because in times of low blood pressure, we don't want to be wasting water and salt out through the urine. We want to be keeping it in. So when angiotensin 2 is active, that is your body's signal that we need to retain salt and water. And it does that by actually clamping down the efferent arteriole. So it actually tenses the angios. So it actually clamps down the efferent arteriole, and then it dilates the afferent arteriole. And you can think about if you have a hose and you pinch one end and you let the other end be really tight, you're going to be getting very low pressure through that system. And so basically it provides a little bit of constriction on the inside, but a lot of constriction on the outside. And so it takes your filtration down to pretty much zero. The problem here comes when especially when patients are doing something like, not only are they low blood volume, so for example, if you were out in the hot sun, if you have a GI illness and you're vomiting or having diarrhea, any situation where your blood pressure is already low. And then on top of that, if you take a nonsteroidal medication like ibuprofen or Aleve, those medications can actually prevent dilation of the afferent arteriole and then make your filtration rate even lower. So not only do you have the effect of the angiotensin 2, but then you've got nonsteroidal medications doing basically the same thing. And this whole several insults on your kidney can actually lead to a pretty bad kidney injury or kidney damage. So in that setting, if you went to the hospital, you might see that your kidney function was really, really low. So this is what we would call a kidney injury, meaning that for a short period of time, your kidney is just not filtering as much blood as it should be. And you have to understand that this is something that your kidney is doing because it thinks this is the right thing to do. It's not that your kidney is actually damaged. It's just responding to signals that shouldn't be there, which is important to understand because I think it gives you a sense of why are these signals happening and what can I do to prevent them. So knowing this, the advice I always give patients, and again, this is not for anyone personally, it's always important to check with your doctor, but what's true is that non-steroidal medications on top of being volume depleted can be a second hit to your kidney. And so this whole situation really can lead to systems of very low blood pressure if you're taking angiotensin converting enzymes plus non-steroidal medications plus getting volume depleted. So really what that boils down to is you just need to be careful with yourself. And I know that that can be frustrating when, you're on the time, especially if you don't feel good some of the time. If on the times you feel good, you do want to go out and do things. But just remember to just be gentle with yourself. Don't be exerting yourself if it's 95 degrees out. Even if you drink a lot of water, can be dangerous. If you have a GI bug, if you got that norovirus in this Christmas time and you were vomiting and having diarrhea, maybe you need to go to the emergency room a little earlier if you start to get weak and lightheaded. So it's not anything really, magical or heroic, but just don't try to brave through things and don't try to muscle through things. If your blood pressure is, getting low, or if you feel like your head is spinning, anything like that, you need to go and get checked out, because those can really cause downstream effects that can be dangerous. So if you needed to hear that, hear it from me. I understand it can be, frustrating, and it's nice to just be able to power through things. But with all of these things going on inside your kidney, especially not knowing if you're one of these people who is going to be having that undetectable but present kidney problem already, just be very gentle with yourself. And then I also wanted to talk about some of the secondary causes that are things that doctors do. The big one that I see is calcineurin inhibitors, so Prograf and cyclosporin, or tacrolimus and cyclosporin, are very old medications. They've been around for a long time. They have a lot of side effects, but we know the side effects. And so they're very good at what they do, which is decrease your immune response and decrease inflammation within your body. So we use these a lot even though scleroderma is a rare disease, we use these medications in kidney transplant patients. And so we actually have tons of data on them from kidney transplant and other kinds of transplants. So I see a lot of patients that have lung transplants and liver transplants and have been on high doses of tacrolimus and now have some long-term kidney damage. So these drugs cause kidney damage in a variety of ways. Number one is that they actually cause even more vasoconstriction of that afferent arteriole. Are you sick of this picture yet? I know but it's really important. So they cause vasoconstriction of that afferent arteriole as well. So angiotensin 2 is doing it. And then if you're taking nonsteroidals, that does it. Having low blood pressure from being dehydrated or volume depleted can also do it. And then calcineurin inhibitors on top of it are just another kick. So Prograf, again, the higher the trough or the level in your blood is, the worse this effect is. And so your doctor, if you're on these medications, your doctor will try to keep you at as low a dose as possible to minimize this effect. And again, no one is on these medications for fun. So if you are on these medications, I don't want you to think like, oh, this is, something that's damaging me. It's always a risk and benefit analysis. But just knowing that this puts you at even higher risk of being vulnerable in states of volume depletion, even more so you need to be careful. This leads, the overall effect of this is that you have a lower glomerular blood flow going through that filter, and then your filtration rate is lower as well. So this can be, it's really a problem of multiple hits to the same system. And unfortunately, we use tacrolimus a lot because it's a drug that we know how to monitor well. It's relatively, safe, and the side effects are relatively manageable. And so a lot of people do have to be on this, especially after transplants, but that's a different story. But it really just kind of paints this whole overall picture for you that you have to be very, very gentle with yourself, and live, maybe even if you're feeling good, maybe live a little bit more, a little bit with your foot, less with your foot on the throttle than you feel like. This also can lead to hypertension. Not sure if I mentioned that. And then another way that calcineurin inhibitors can actually lead to longer term damage is that they can actually directly cause damage to the tubular cells of your kidney, and that's actually part of the collecting system. Once the urine has been made, it actually is refined, and so not the filtering part, but the downstream part can actually cause damage. So you can see here over time this little white space in picture A, that little sort of donut. The purple part is the wall, and that becomes thicker and thicker over time. And you can see in the rightmost picture, in picture C, that you almost can't get any urine through that hole anymore. And so basically that's a defunct nephron now. So there is also some data that the cells in your kidney that make the renin might actually be more susceptible to this type of damage. So this is a known side effect. Everyone that is on tacrolimus will get, especially at higher doses, will get some kidney damage over time, and we know that. But if it's helping with overall disease, then sometimes that's just a risk we accept. So again, a variety of mechanisms. Sometimes the disease is causing the problem, and sometimes the solution to the disease causes the problem. The other thing, so just, in summary, I hope that's given you kind of a sense of all the different ways your kidney can become involved. But also, I was looking through the data here and just going, man, there's just not a lot of research being done, especially on kidney disease in uh, scleroderma, but in scleroderma at all. And so I really can imagine that as a patient, that would feel like, you know, isn't anyone trying to fix this? And so I wanted to point out a couple studies I thought were really cool that are in the works. Number one here on the right, this is just a study that was published at CHEST, which is a big critical care and pulmonary conference. In 2023, this was a spectrum of renal manifestations in scleroderma. It was a review that was done. And so interesting to me that pulmonary physicians care about this because, of course, pulmonary hypertension is closely related. And then on the left here, there's a clinical trial ongoing for assessment. This is not in the United States, but it's an assessment of early detection of renal impairment, both in lupus and scleroderma. So I thought that this was really interesting. Again, this is not recruiting anymore, just something to keep an eye on, but I wanted you guys to know that this is something that there is active, although there's not a ton of data right now. This is something that people are actively looking into. So these would both be something I would consider like biomarkers and disease state. And then there's also a couple studies of intervention. So there are a few clinical trials that are ongoing or being published with different, two of these are endothelin receptor antagonists. And so these are sort of along that pathway of ACE inhibition that I mentioned. And then the guselkumab is a drug that's actually used right now in, I believe, psoriasis and is being trialed in systemic sclerosis. So again, I believe all of these are done recruiting or I'm not suggesting that you take part in any of these, of course, but I just wanted you to know that there is a lot of active ongoing research. And so please don't think that no one's working on this because there are a lot of things in the pipelines that I think are really promising. So what can you do as a patient? First and foremost, get a home blood pressure cuff and follow your blood pressure closely with it. Please don't only take your blood pressure when you're stressed. Take it every day or every Sunday or once a month. Whatever it is, write it down in a place where you won't lose it. And if it starts to creep up, don't be quiet about that. Let your rheumatologist know, let your primary care doctor know. Be aware of that. So follow it very closely. Remember that blood pressure is not something you can sense with, you cannot rely on. Some people do have headaches, swelling, things like that, but you can't rely on that. So don't assume that because you feel okay, your blood pressure is okay. All right. Be aware of any potential side effects of medications. If you're on any additional medications, don't just say, are there side effects? Say, could this predispose me to getting volume depleted? Will this make me urinate more? Will this drop my blood pressure? Even situations like being sick, particularly with GI illness, not skipping meals, for example, if you're on vacation, particularly if you're going on like a long hike, make sure you take food with you. Don't be skipping meals. Any situations that might make your blood pressure low, please be very, very aware of those. You need to sort of baby yourself, take care of yourself. And then consider enrolling in a patient registry. This is something you could talk to your rheumatologist about. These aren't really clinical trials. These are basically just ways of keeping track of how patients do over time. And again, if people hadn't volunteered to be in these clinical cohorts that I've mentioned today, we wouldn't have any data whatsoever. So, enrolling in a patient registry is a great way to make sure that your experience is counting for something and being counted. I'm not necessarily advocating for anyone being in a clinical trial. That's a decision between you and your rheumatologist and, your family. But being in a patient registry is just saying, yes, you can watch, you can include my information over time when you're counting people. It's basically like using your experience to vote. And so those are really important to our understanding, particularly of rare diseases. And I know I'm preaching to the choir because you're all here at this talk today. But again, just, it really is important. And then the last thing is just, I know that you're all aware that, scientific research is always, it's not a huge priority for people because it's not something that pays off immediately. And it's not a financially advantageous thing for the most part. Understanding diseases, especially understanding rare diseases, is a very long road. But, it's really important. And if we don't all speak up for our patients and for ourselves and for our family members and say, hey, look, I know it's not going to make you any money to fix my disease, but you know, this is a priority for me. Make that voice heard. Tell your Congress people, tell your, whoever, controls the purse strings in your neighborhood and for your state. Make sure that people know that scientific research is important to you. Because that's the only way we move things forward. In my time as a short time as a doctor, I've seen things that used to be deadly: hepatitis C, cystic fibrosis, all kinds of illnesses that have been effectively cured. And we can't do that without a lot of research. So I appreciate you all being interested in things like this. And I know that you're the ones that holler about stuff, but I just want to encourage you that really is important. So thank you for your attention. Thank you for your hard work. Thank you for being here and caring about this. This is my dog, who is named aldosterone. That last molecule in the pathway. What can I say? I'm a nerd. But so I think we have a little bit of time for any questions you might have, any comments you might have. And if not, here is my email address, and you're always welcome to shoot me an email, or you can follow me on Twitter or X if you dare to go on there.
Thank you, Dr. Gaddy. That was a
You.
fantastic session. I loved your closing
Thank
comments,
you.
especially reminding everyone to one, baby themselves. That's huge. We all need that reminder. And I think, encouraging folks to take part in those registries is huge, especially for, a disease like ours that's small, and even highlighting some of those numbers in the studies that you referenced, it shows that we need that participation. So thank you, and thank you to our
Mhm.
audience. We do have a few questions here. I'll go ahead and get started. So the first question is, what are some of the physical symptoms that someone might experience with renal crisis or when their kidneys are being overtaxed?
Oh, that's a great question. So unfortunately, I mean, some people do have symptoms. I don't want to discount. Some people do have symptoms. But the problem is that they're not reliable. So some of the symptoms, though, to look out for, definitely getting routine labs is important. Every year you should be getting a basic metabolic panel, like a chemistry, to make sure that your kidneys are cleaning your blood as well as they should be. And also your urine should be checked for protein. And that's just, you just pee in a cup. It's not, you don't have to do a 24-hour. But any swelling in your legs, any swelling in your face, any swelling in your abdomen that's outside of what, not like just eating a big meal, but like any belly swelling where you feel like you have liquid in your belly, huge signs that you need to get checked out. Headache or feeling, or your blood pressure actually being high is actually a symptom of kidney disease, right? Because your kidney isn't getting rid of extra salt and water the way it should be. So if your blood pressure is creeping up, go get checked out. Um, but that's really it. So kidneys don't tend to cause a lot of problems. The other problem with kidneys is that you've got a lot of redundant, you've got millions of filtering units in your kidney. And so you can have a lot of them drop off before you start to see actual problems. And so this is why it's just really important to keep it, sometimes I wish I had picked a field that had more symptoms. Like, I'm glad my patients feel good, but a lot of times you can be really sick before you start to feel bad. So it's really just getting to your doctor's appointment every year and making sure someone's drawing your blood, someone's looking at your urine once a year, outside of just the blood pressure, which is, I already said. Does it matter the antibody RNA number?
Yeah.
I assume that you mean like 1 versus 3. Yes, it does. So there's lots of different types of anti-RNA synthetases, and only number 3 is actually correlated to predisposition to a scleroderma renal crisis. If you mean the level, then yes, it does matter.
And then if you had suffered kidney damage, can it be reversed in any way?
That's a great question also. So the good news is that you actually have a lot of residual, like I said, it's almost like the liver, where it can almost sort of, oh, yep, number 3. Yes, number 3 is the specific one that is specific for scleroderma renal crisis. Yep. Um, so sometimes it can, sometimes it can't. It depends on how long the damage was going on and whether it was actually just, as I mentioned, your kidney oftentimes just shuts down blood flow in times of low blood pressure because it thinks it's doing you a favor. And if it just happens for a little bit of time, then that's reversed and your kidney gets all the blood flow back and it's happy. This is part of the process. But sometimes if your blood pressure gets too low, then your kidney itself suffers from the lack of blood flow. It's actually ischemic damage, meaning it's just not getting blood flow and the cells die off. And when the cells die off, they can grow back, but it's never quite how it was. So there are some types of damage that are more sustained. And in that situation, I think it's important, for you guys to seek care with a specialist kind of early, especially if you don't know what caused the problem. Because, there's not a whole lot of kidney damage that is reversible, but most of the time the reversible stuff is just from your blood pressure being too low. And then if we can restore your blood pressure in an appropriate amount of time, then that can be limited. Um, but it's important to follow with somebody, particularly, if you're lucky enough to be in an area where you can do this, to have a rheumatologist or whoever's quarterbacking your scleroderma care. If you can get a nephrologist that's in the same, or primary care doctor and nephrologist that are all in the same system so that they can all talk to each other and they can all, see each other's charts and things like that, it does make things a lot easier for you and for them. So not always, but the more tightly you watch things, the more chances there are that it can be reversed.
Thank you. I think that's very hopeful for everyone. And the next question here we have is electrolyte drinks are all the rage right now. Are they
Great question.
counterindicated in people with kidney disease?
Yeah, great question. So they're not electrolyte drinks. So that's one of those questions that like I would encourage you to think of an electrolyte drink as basically it's just all the things that are in food, so potassium, sodium, but it just it happens to just be in water. So there's nothing contraindicated in them, but if you have high blood pressure, then you might be drinking a lot of salt because electrolyte's just a fancy word for salt. So some salts and a little bit of potassium, but mostly it's salt and potassium. So just be careful if your nephrologist or primary care doctor says, um, if your primary care doctor says that you have like high blood pressure or that your potassium's getting high, then you want to watch how much you drink. So no, they're not. And they can be particularly useful if you're like working out and sweating a lot, then maybe they would really help you keep your blood pressure normal in those times. Um,
Thank you. That's
so
very
I
important.
don't dislike them. They just have their place. I tend to tell my patients more, if you feel like you're doing if you're working out or out in the hot sun, I tend to say just eat a salty snack and then drink water because that kind of helps you. Your thirst is a very, very strong indicator of how much water you need. So I tend to be more in like eat some salty peanuts to get some protein and stuff too. But if you tend to work out and then like want some Gatorade or something, that's absolutely fine.
Important to know. And there's a follow-up for the prior question related
Yep.
to the RNA numbers. Do you want me to read it or
Yeah, no, I can read it. So the
perfect.
question
You
is,
got it right
Sarah
there.
is asking if the 21 versus a different number. Okay, so yeah, so the titer, yeah, so what we call that the titer, meaning like what's your actual level of that in your blood? And yeah, that does matter. So I don't actually know what the cutoff is for being positive, and those tend to differ from lab to lab. I apologize, I don't know what the cutoff is. Higher is generally a more would be worse. But it's not always like linear in terms of if your risk is, if you have a 40, then your risk is half what it is if it's 80. Sometimes it's just if it's over a certain threshold, then you have a higher risk. So it depends on how the study was done. So I apologize, I don't know what the normal is for that one. So it may be that like 20 or lower is normal and 80 or greater is higher. So that just depends on the lab.
Thank you, Dr. Gaddy. And I had a question. You had talked a little bit about the elevated renin numbers
Mhm.
and how that could potentially be used for maybe
Yeah.
earlier detection.
Yeah.
Um, is that something that, some of our patients can bring up in a conversation with their physicians? Let's say, they may be earlier diagnosed in scleroderma and they're trying to be very proactive in their care.
It is. I mean, right now, know that there are not studies, to my knowledge, and this might be part of that study that I had mentioned that's ongoing. Right now, there isn't like a threshold. There aren't and that's part of the difficulty is that there is not guidelines about these things. We have never taken a huge cohort of people and said, once your serum renin level gets to 10, that's when you're at high risk. That's when we should start. It's always going to be until, I mean, probably never, because again, scleroderma is thankfully a very uncommon disease, but it's going to be somewhat judgment based. There are going to be people who are dramatically high, and that's an easy decision. And there's going to be people who are zero, and that's an easy decision. But then there's always a lot of gray space where it's like, well, should we? And so I think it is something they definitely should bring up, particularly with a nephrologist if they're seeing a nephrologist. But yeah, it's bringing that literature in can also be helpful. And then keeping an eye on the clinical trials that are done. And when those are published, seeing what reference ranges were used in the clinical trial is a great way of actually knowing whether there was any significance found to that. Because it's by my intuition and by the logical mechanism, that's a good risk marker. But maybe when you take a group of 1,000 people, it winds up not being significant. So there's always a kind of a sweet spot between personalized medicine and learning from big groups of statistics what's clinically significant. But I think it's something definitely to keep an eye on. And certainly if your blood pressure starts to get high, even like a little high, even a tiny bit high or high for you, bring it up.
I think that's a great point for everyone on the call. And thank you so much for joining us. We're coming just about up to time. I want to give a huge thank you to you, Dr. Anna Gaddy, for joining us today and giving this fantastic presentation. I want to give a big shout out to our Upper Great Lakes chapter. I want to give a shout out to Randy Slickers, Cami Novacek, Peggy Collins for helping organize these events. The Lunch and Learn series does take place every month, so keep an eye out for future announcements. And Dr. Gaddy, do you have any closing words for our audience?
No, keep doing the work you're doing.
Awesome.
It's
Thank you
amazing.
so
Thank
much.
you so much. Thanks for having me.
Awesome. Take care. And I hope
Bye.
everyone has a wonderful day. Bye bye.